Thank you, Mrs. Bellington. And I would like to talk to you about the action plan for FH pediatric screening in Europe. Already in 2013, a group of European Atherosclerosis Society performed a consensus statement: familial hypercholesterolemia is underdiagnosed and undertreated in the general population. Guidance for clinicians to prevent coronary heart disease. But even 8 years later, a few weeks ago, in the Lancet publication, there was a study performed in 42,000 adults from 56 countries with the following conclusion: FH is still diagnosed late, median age 44. B, the guideline of LDLC is infrequently achieved with single drug therapy. And furthermore, the presence of coronary disease were lower amongst screened cases who were diagnosed earlier. And earlier detection and greater use of combination therapies are required to reduce the global burden of FH. There is a burden of FH if you look at the European region, 1.8 million up till 4.5 million. For the European Union, it's between 1 and 2.5 million people, depending on 1 in 500 or 1 in 200. In the past, it was assumed 1 in 500, and everybody was applauding for Norway and the Netherlands, but we now know it's much more frequent. And there is still a lot to do, because familial hypercholesterolemia in children and adolescents will give decades of healthy life years by optimizing detection and treatment. And FH is not rare. Here you see the Duchenne, cystic fibrosis, neurofibromatosis, Huntington disease, sickle cell disease, all very known, but this is FH, the huge column. And 2 recent publications within 1 week show that the frequency of heterozygous FH worldwide is 1 in 300, 311 up till 330. Was done in meta-analysis of 7 million and of 11 million people. So this means for the European Union, around 300,000 children with FH and 1.2 million adults with FH, and yet less than 10% are discovered. Homozygous FH is a chapter on its own. 4-year-old boy who died in kindergarten with a very high cholesterol on atorvastatin ezetimibe, died suddenly at the age of 4, and there was 98% occlusion of the left coronary artery, only 2% left where all the blood had to go through. These signs of orange-like eruptive xanthomas are for opportunistic screening. You should know this is homozygous FH and should start or apheresis or other types of drugs. We recently published in the upper part, you see the plaques in orange, and after 1.5 year treatment, the plaques were gone. So fat can come out of the vessel wall and it can't become calcified. That's the whole idea about early detection and treatment. Why screening of children with heterozygous FH? Heterozygous FH in childhood causes an 11-fold increased risk of heart attack in men, and even a higher risk, 17-fold increased risk of heart attack in women between the age of 25 and 40. The former was from Norway, this is from the United States. Compared to a normal LDLC and no mutation associated with FH, those with high LDLC, above 5, and no mutation have a 6-fold increased risk of heart attack and stroke, whereas those with high LDLC and the mutation have a 22-fold higher risk because it starts at birth. Here is what it's all about. This is the back years, not of cigarettes, but of cholesterol. Unaffected individuals cross a line, let's say at the age of 70, then the heterozygous FH cross that line at 35 and homozygous at the age of 7. So if we do ultrasounds routinely, and we compare the non-FH with heterozygous FH, the non-FH have a thickness of the IMT of 0.8 millimeters at the age of 80, but heterozygous has it already at the age of 40, before the age of 40. And you can bend the line by starting drug treatment at 30, you bend it a bit. You start at 20, you bend it even more. You start at 15, even better. But nowadays we believe as soon as possible, lower the cholesterol and you have the same line as the unaffected siblings. And this is shown in the 20 years follow-up children with FH versus parents with FH. I already showed you about the Dutch experience. What we published in New England is that the parents started at the age of 30 and 40% had a heart attack before the age of 40. And 11 died before that age of the 156 parents, whereas the children, none of them died. One got a stent at the age of 28 because he stopped his drugs at 18. Family history of premature cardiovascular disease plus high LDL-C are the two key selective screening criteria. F plus H is FH. Twice an LDL above 5 is highly probable FH. Twice above 4 and premature early cardiovascular disease, heart attacks, highly probable. Twice above 3.5 and a genetic diagnosis in a parent, highly probable, and proven pathogenic mutation in a child is definite FH. So this is a flow diagram. You can enter via the child or via the parent, and you know if it's needed to treat. And it is highly cost effective. We compared FH screening with colon cancer, breast cancer, and cervix cancer, and it's a cost-effective way of screening. So the main recommendations extracted from the action plan: every European country should have a familial hypercholesterolemia early detection screening, diagnosis, and care program focused on childhood identification and treatment, building on existing good practices and partnerships. 2, screening programs should include a combination of cascade, universal, and opportunistic strategies based on cholesterol testing, that's fine, FH genetic testing, or ideally a combination, and occur during regular healthcare visits, community settings, or perinatal period. And finally, 3, the government healthcare budgets should support investment in uptake of relevant best practice models from other countries, developing a European network of exchange and shared learning. And finally, research to support childhood FH identification should include registries documenting FH care and to monitor progress and health outcomes. Thank you for your attention, and back to Nicola.